Hi everyone, this is Janet Hill with the Rock Island County Health Department. Thank you for joining us. It's 3:30 p.m. on December 3rd. Today with us we have Dr. Louis Katz, who is going to be giving a lot of really important information about the upcoming COVID-19 vaccine. First of all, though, we want to provide you with our numbers. In Rock Island County today, unfortunately, we have 7 deaths to report, bringing our total number to 164. We offer our sincere condolences and comforting thoughts to the families of these residents. We also have 126 new cases of COVID-19, bringing the total to 8,764. We currently have 77 patients in Rock Island County Hospital. Thank you. Ed?
In Scott County, the number of cases is 11,744, and we've had 90 deaths. As has been covered in the media and addressed by Iowa Governor Kim Reynolds earlier today, COVID-19 vaccine will slowly become available in our community this month. Vaccine production is just beginning, and the first shipments of vaccine will be reserved for healthcare workers and others at high risk of being exposed. As more vaccine is available, other priority groups will be included. Production will increase in 2021, and there will eventually be enough for everyone who would like to receive it. Public health and our healthcare partners have been diligently crafting a plan for distribution and administration of the vaccine when it's received in our community. We ask for your patience as the process begins. We recognize the vital role you all play in our community as workers, teachers, leaders, providers, and families. In time, there will be enough vaccine available for all. We've asked Dr. Louis Katz, the Scott County Medical Director, to provide an overview of the COVID-19 vaccine and answer questions we know are important to our community.
Hello, everybody. Thanks for your interest. I want to address a number of issues. I'm going to try and do it quickly. If I go too fast, you can stop me and ask questions. The thing that I'm being asked most often by the general public and indeed by a lot of my medical colleagues is whether the COVID vaccines are being rushed. And I want to make the case very, very clearly that that is not the case, that while the speed with which these vaccines may become available is unprecedented, it's not because any of the testing has been shortcut in any way. What's happened is that tasks that usually occur one after the other are being done in parallel. So, for example, the vaccine testing in clinical trials is ongoing at the same time the companies in the FDA, for example, are developing facilities compliant with what's called good manufacturing practices. That normally wouldn't happen until after a company had an approvable vaccine. So it's parallel instead of serial development that has hurried things along. The other thing that I want to tell you is that the independent panels reviewing the vaccines, called data safety monitoring boards for Operation Warp Speed, are totally independent of FDA and Health and Human Services. These are not political committees. In fact, the only political appointee in any way, shape, or form involved in decisions about this vaccine is the FDA commissioner, but the professionals at the agency, at the Center for Biologics Evaluation and Response, the director and the people who report to him are in fact all career MD scientists at the agency and have no political affiliations. Finally, the independent advisory committee that will make recommendations to the FDA about the Pfizer vaccine on the 10th and the Moderna vaccine on the 17th of this month. The vaccines and related biologic product advisory committee are all independent, unpaid subject matter experts, some of whom I have worked with in the past and in whom I have explicit and implicit faith in their independence. The vaccine candidates of interest, there are actually 7 that Operation Warp Speed has gotten behind, but there are really 3 that have been in the news recently. The 2 messenger RNA vaccines, Moderna and Pfizer BioNTech. Those are the 2 that will be, that have asked for emergency use authorization from FDA, and AstraZeneca and the University of Oxford that you've heard about recently that I think will apply for an emergency use authorization in the relatively near future, but has not yet. So the ones we're interested in right now are Moderna, BioNTech, Pfizer, and their messenger RNA vaccines. They have gone through phase 1, 2, and 3 studies. Phase 1 for safety, 10 to 100 patients. Phase 2 for safety and immune response, hundreds of patients, subjects. And phase 3, tens of thousands for safety and effectiveness. They have now applied for an emergency use authorization, which is short of full approval, but will allow us to get the vaccines out ahead of full approval if the FDA grants the EUAs. Then there's approval, the full licensure of the vaccine, like is done for any other vaccine, which will require, again, full review, all the data that is accumulated since we assume EUAs will be granted. But after the EUAs, as data develops, they'll be used in the approval. Then there'll be what's called phase 4 or post-marketing studies designed to assure the long-term safety of the vaccines. I don't have time to go into what's going to be done for that, maybe at a later date, but there are over a dozen systems existing or being developed for the post-marketing surveillance, primarily about the safety and duration of protection from these vaccines. I am very impressed with the speed and very confident that the process has not been shortcut in any way, shape, or form. So the Moderna vaccine has shown 94.5% effectiveness against infection, against clinical infection. The BioNTech Pfizer vaccine, 95%. Both appear to be effective against severe disease. The AstraZeneca vaccine is 62 to 90, depending on the regimen. And the differences between their regimens are really, the explanation of those differences will slow down their process. Both Pfizer and Moderna have stated in their media releases that there are no serious safety concerns, quote unquote. A severe adverse event is defined as anything bad enough to interrupt activities of daily living. So what we're looking at with the Moderna vaccine are rates of fatigue, muscle pain, joint pain, headache, fever, all less than 10%. The data available on the Pfizer BioNTech vaccine look the same, but are much less robust data. All of this comes from media releases. And so I guess my question to you would be, how many press releases does it take before it's data? Well, we don't make our decisions based on press releases. So the first time extensive data will be reviewed are at the FDA advisory committee meetings on the 10th and the 17th. And I will unfortunately sit through both of those so that I can see the vaccine data as it's presented to FDA completely. This is 2 months of follow-up in these studies. Normally a vaccine would have substantially more than that, but we're in the middle of a public health emergency. And I think not waiting for 6 to 12 months of data is totally appropriate at this time. Again, that's short, but I think it's justified by the emergency. Please recall that we already, in 9 months of the pandemic, or slightly more, have more deaths in the United States than all of the military conflicts that we've been involved in since I was born in 1950. That's 9 months and over 250,000 deaths. So I think we're justified in moving towards emergency use authorization as opposed to full approval. We have multiple systems in place to monitor safety after the introduction. And I will point out that serious adverse effects are very, very uncommon at intervals longer than a few weeks after completion of immunization historically. The only two that I think are interesting here are atypical measles in 1967 and respiratory syncytial virus also, as a matter of fact, in 1960. Measles was 57, I think. RSV was 1967. Those are really the only two where anything important was recognized longer than 2 months following completion of the immunization series. So I think vigilance is critically important, but I think the risk is quite low at this point. There's been an extensive priority setting activity going on since spring for the vaccines, both at the National Academies of Science, Engineering, and Medicine, and at the CDC. If you go to the National Academy's website, you can find an extensive document, it's about 80 pages, on their development of a vaccine priority framework, which was available to the CDC ACIP for their deliberations. And the two approaches are very similar. The effort to prioritize has been based on science, issues around implementation of an urgent vaccine program, and the ethics of how we distribute these vaccines. The ethical principles that have been adhered to are to maximize benefits, minimize harm, promote justice, and mitigate and minimize health inequities. I recommend the National Academies of Sciences document to you. It's on the web. If you can't find it, let me know and I'll get it to you. So phase 1 has been broken into phase 1A, B, and C by CDC. On the first, the ACIP, the Advisory Committee on Immunization Practices, voted 13-1 to give the initial supply of vaccine to healthcare workers and to residents in long-term care. That was a 13-1 vote, and that's where we are now. Phase 1B has not been finalized, but is going to be essential workers, education, food and agriculture, utilities, police, fire, and transportation are the groups that I think will be included in phase 1B that I expect is going to start happening late January or February. Phase 1C after that will be adults with high-risk medical conditions and adults older than 65. Phases 2, 3, and possibly 4 will expand availability from there. One of the biggest issues in how well the vaccine works, how well these vaccines, how rapidly they will allow us to return more towards normal, is who will take the vaccine. The best survey data that exists now suggests that approximately half of the overall population is willing to take a vaccine now, and half is either not sure or doesn't intend to take the vaccine. That varies by race, ethnicity, and age, but overall, 50% of people are skeptical. The skepticism comes from many different sources. The main thing that comes to my attention are two things. One, concern that the vaccine has been rushed. I don't think that's the case. And the other is a general vaccine skepticism that I think is inappropriate, but is more difficult to deal with, I think, than the rushing issue. As Ed told you, we think the vaccines will become available shortly after the VRBPAC committee meetings on the 10th, and then again on the 17th. And we have some preliminary information about distributions to Iowa that assume both that the EUAs will be granted quickly and that the companies will have and be able to ship the vaccine on time. Will I take the vaccine? I will take it on the first day that it is available to me. Public health workers are in the healthcare worker priority groups that CDC voted on. So the first day that I can take it, I will. This is based on the data and assumes that the efficacy data are confirmed at the VRBPAC committee meetings and that no new safety concerns are raised. If that's true, I think the data are fully in support in this public health emergency. There's another reason that I'll take the vaccine on the first day, that I can get at it. I spent 7 years in Washington, D.C. Doing blood banking and interacting sometimes on a daily basis with the leadership of the Center for Biologics Evaluation and Research at FDA. These people are colleagues and friends of mine. While I was not terribly involved in vaccine regulation, this is the same center at FDA that regulates blood products. Peter Marks is the director of the Centers for Biologics Evaluation and Research. He is a colleague and a friend. I've spent a lot of time with him on the phone over the last 9 months discussing issues related both to convalescent plasma, which has influenced the blood community, but also the vaccine development process. I trust him implicitly, and he and I would take the shot together on national TV if that's what it took to convince people. So I'm going beyond the science to a personal relationship with the people that are making the hard decisions about emergency use authorization and approval, and I would trust them with my safety, frankly. Now, I wanted to touch on one other thing before we quit. The vaccine is in some sense the holy grail of our response to COVID-19. Under the best of circumstances, assuming that the emergency use authorizations are granted, it's going to take many months to roll out enough vaccine to immunize everybody who should be immunized and will be immunized. In the meantime, the need for following the non-pharmaceutical interventions that we've been recommending for many, many months is not diminished in any way. And in fact, with the vaccine light at the end of the tunnel, the need for physical and social distancing, masking, hand hygiene, and the rest of the things we've been talking about is probably increased. With a vaccine likely to become available quickly and expanding its use over a period of several months, what would be more terrible than getting sick and having a bad outcome while we're waiting for a vaccine? So I want to make the case very, very aggressively that under no circumstances should anybody be backing off on masks, physical and social distancing, hand hygiene, reasonable control of our environment while this happens. It is critically important that people now double down on all those things so that we don't have needless loss of life while many of us wait for a vaccine. I'm done and can take questions.
Thank you, Dr. Katz. I did prep a couple of questions, just recognizing that we have you on here and we can just talk some vaccine basics. So I wanted to prep you with a couple of those, and then we do ask media partners to type questions into the chat for Dr. Katz. Just kind of, again, going back to basics, quite often when children or an adult get a vaccine, they may experience a fever shortly after. Does this mean the vaccine is making them ill, or why is this potentially a good thing?
Well, fever after vaccines is actually, particularly live virus vaccines, is quite common. These aren't really live virus vaccines, but they have some features of it. And that's generally caused by a brisk immune response to the virus. And that's what we're trying to do. In this case, to the RNA that's part of the vaccine.
Okay. Next question, you did mention the side effects, which we do want people to expect, but you've recognized that that's something that only occurs in potentially about 10% of cases. Should this scare people? Why not?
No, as I told you, most of those side effects are generally felt to represent the immune response to the vaccine. It's the vaccine doing what it's supposed to do. The critical thing, and I said this very clearly to the medical societies yesterday, the critical thing is that people giving the vaccine, the docs and nurses and healthcare providers and pharmacists giving the vaccine, need to be upfront with everybody who's getting it so they know what to expect and what to do if it happens. Again, the data that we have to date, both what's been in the press releases and what I've been able to get from my colleagues at FDA, suggests no really serious adverse events. So people need to know that they may feel bad for a day or two, fatigue, sore arm, even a fever, but that is in general expected, and they need to know what to do if they experience those symptoms.
And then going back to, the need for this vaccine for the larger population or the larger community, can you just describe how, for example, how does me getting a vaccine help to protect others as well?
Well, one of the things that we're not sure about yet with these vaccines is whether they prevent transmission. My guess is that they're going to be reasonably effective at preventing transmission. So the idea is that healthy people who are going to do well if they get it may be less likely to transmit. But most importantly, and the reason that we're doing prioritization, is that the people who are likely to get sick and do badly will then be immune. So it's at both ends of the equation. Certainly keeping you, a healthy person, from getting sick is important, but we're very hopeful it will also prevent you, if you become infected, from transmitting. More importantly, in the short run, is to provide immunity to the people who are likely to do badly if they become infected. And the early data that we've seen from the phase 3 trials of these two vaccines suggests a very good efficacy against severe bad outcomes in the vaccinated groups. So it works from both ends.
Thank you. And can you speak to why kids won't be vaccinated early on as part of this process?
Well, as the prioritization principles that I shared with you suggest, we're starting out trying to maximize benefit and minimize harm as early as possible. So immunizing healthcare workers first preserves our capacity to take care both of people with COVID-19 and people with all the other things that require healthcare. So that's part of maximizing benefit, goes beyond preventing COVID-19 to preserving our capacity to take care of sick people. So that's prioritization one. The other thing in terms of maximizing benefit, and the reason that people in long-term care have been put on the high end of the priority list, is they represent 6% of the infections and 40% of the deaths. So we're trying to get the most bang for the buck as quickly as possible. And the deliberations that have led to these priorities involve the analysis of lots of complicated data that I can't go through in this venue, but I think those are the right decisions in terms of maximizing benefit, minimizing harm. Starting with the priority groups that I mentioned earlier is the right way to go.
Okay, and now I'm going to go to the chat. There's a couple questions in there. I'll start with the one that connects to what you just said. Can you speak generally about what the timeline looks like for the general public? We know that there's some phases. We don't have exact dates, but what can the general public begin to expect on when it would be available more broadly?
Well, yeah, it is going to be in phases. It's going to depend on the ramp up of whatever vaccines get emergency use authorization, ramp up of manufacturing and distribution, what other vaccines and additional capacity become available and when. But I think it is optimistic to think that the general public is going to have broad access to the vaccine any earlier than the end of second quarter, beginning of third quarter. I hope I'm wrong. I hope it's faster than that. But my discussions with whoever I can talk to suggest that broad availability probably late in the second quarter.
So we're talking potentially late spring, early summer. Is that what it sounds like?
Yeah, May and June. Nobody can imagine how huge this undertaking is. So I think that's optimistic, but we're ahead of schedule already. So I've decided to be optimistic.
And then I know as part of the plans, recognizing that some of the vaccine that's coming needs to have that ultra cold storage. Can you just speak to the planning that's in place for capacity for those types of things generally in our area?
Yeah, the ultra cold vaccine from Pfizer will go to areas of the state that have the capacity to store ultra cold. I assume that the Moderna vaccine is going to get an EUA shortly after the Pfizer vaccine. And that vaccine, which has more forgiving storage characteristics, just needs to be frozen at the temperatures that you can attain in your refrigerator, for example. Those doses will go to places that don't have the capacity to store ultra cold and distribute in a fashion that will protect the integrity of the vaccines. It's a good approach. It's an excellent approach. We will get vaccine in the metro area for the ultra cold. There are at least 2 places that I'm aware of, and I ain't going to tell you where, that have that capacity.
Great, thank you. I had one additional question that was here on my list, and then if we have any others from the media, please type it in. What can you tell us about how long potential immunity could last from this vaccine? And is this something individuals may need a booster or may need to look at a yearly vaccination?
Yeah, I didn't go into that because all I was going to tell you is it's on the list of things we don't know. The duration of immunity, of the impact, the effects that we've seen in the phase 3 trials is unknown. We're out past 2 months. Things look good. There was a study published today on one of the preprint servers on the Moderna vaccine that the things we measure in a test tube appeared from the phase 1 studies in the early spring appear to persist out as long as almost 6 months. But the bottom line is we don't know because we really only have 2 months of data. So I can tell you about 2 months. I can't tell you about 3, 4, 5, or 6 months. We don't know about the safety of administering these vaccines with a flu shot. We don't know about pregnancy and breastfeeding. We don't know about the need for boosters. So you're going to have to, everybody's going to have to take a deep breath, be patient, and we're going to learn this as we move forward.
Thank you. I do see a couple of questions here for both Ed and Janet. Ed, it was discussed on the governor's call this morning. Iowa health officials say the first batch will go to six major healthcare sites around the state. Who's getting them? What do you have to provide to that?
The state will not be releasing that information, but as you heard Dr. Katz say, there are fairly rigorous requirements for storage. So the sites would be selected based on location, the ability to provide security, and to provide the proper storage in sufficient quantities.
Thank you. And Janet, perhaps you can answer this one. Are you starting to see indications that there may be a post-holiday surge beginning? And our testing places seeing high demand for that post-Thanksgiving window that we're potentially anticipating?
Well, the week of Thanksgiving, we were reporting about 60 cases a day. And the last few days, we've reported more than 120 each day. So, you know, we know that a lot of times people get sick 5 to 7 days after their exposure. So we are exactly in that window from Thanksgiving. So I think we need a couple more days of data, but basically we are bracing for it. We believe that people did not follow public health guidance in all cases. We are really happy that a lot of people did, but we do know that some people just went about their life as if there was no pandemic.
Thank you. I don't see any additional questions. Dr. Katz, do you have any closing thoughts?
Well, the only thing I want to reemphasize, and I've said this previously, I'll say it again, I consider under the circumstances we're living now, that the media are part of the healthcare infrastructure, the public healthcare infrastructure. And I believe it's your responsibility, however you hype these vaccines, about which we have a lot of information, maybe not as much as we want, but the critical message that goes with the good news about vaccines is the increased importance of following non-pharmaceutical interventions that we've been recommending since the spring.
Thank you very much. I did want to put information out there for all of you as you're reporting on this. Information on the COVID-19 vaccine is available locally. Both the Scott County Health Department and Rock Island County Health Department have information on the website. The QC COVID-19 Coalition has information on the vaccine on the website as well. And so we're encouraging individuals to use some of these credible resources to get information. It connects back to the CDC as well as both state health departments. There's access to good frequently asked questions on there that expand upon some of the information Dr. Katz shared. Additionally, we'll be posting the link to this briefing on our website as well as social media pages, so please check those out there should you need any other information. Thank you all for joining us. Thank you, Dr. Katz, for sharing your time with us today. Wishing all of you a good afternoon, and we'll talk with you again next week.